I think in the interest of timekeeping, we might make a start. Thank you, everybody, for attending our Macular Milestones research update. So just as a matter of housekeeping, there are bathrooms on this level. So if you go through that door on the left, there are some bathrooms. If you go to the back, follow the signs, there's some bathrooms near the staircases, the main foyer entrance. So before we begin formally, it's appropriate to acknowledge the traditional custodians of this land, the Gadigal people, and we pay our respects to elders and communities, past, present and emerging. So our first speaker needs no introduction, Professor Mark Gillies. He's going to tell us about his work on the MacTel project. Thank you, Mark.
Thanks, Matt. Perhaps we could have the lights turned down because to make the screen easier to see here. So talking now about macular telangiectasia type 2 or MacTel, a complicated name, but it's actually quite a common macular condition. It's not age-related macular degeneration, but it is certainly a macular disease which just affects the macula and nothing else. We've been involved in researching this condition, and we think that many of the insights we're getting out of this is something that may help treatment of macular degeneration in general. But it's a very specific disease. So there's two types of MacTel. The number one is aneurysmal, where you get the abnormal blood vessels. Telangiectasia is like varicose veins. It's swollen veins, but on a very small level that you can see here just in the macula. And type 1, they get in just one eye and they get this swelling. It's very obvious, as you'd expect. Type 2 is a very peculiar condition. You can see here two maculas again. You always get it in both eyes, and you get the leaking of the fluorescein dye, but it doesn't swell up for some reason that we don't quite understand. And this is what it looks like on the OCT, optical coherence tomography, which we look at all our patients with these days. And the problem here is the retina's collapsing down, and we've lost the photoreceptors, this band here, also called the ellipsoid zone. So when we started this project, we thought it was a disease of blood vessels, but it turns out it's a disease of these glial cells called Mueller cells that we'll get to in a moment, and they support the photoreceptors, and the death of the Mueller cells causes the blood vessel abnormalities, but it also causes the Mueller cells to die, the photoreceptors to die, and that's how you lose the vision. As clinicians, this is the sort of thing we see on the angiogram. You see the blood vessels start to leak there, the retina gets a bit opaque, these right angle vessels, and then you get these pigment plaques, and some people get bleeding, just like wet macular degeneration, but that's only about 10 or 20% of people. Most of the time they don't get that. One of the big findings here is another test. If you go to the eye doctor, when they've shown the really bright blue light in your eye, that's the autofluorescence. You can see this. Normally you have this luteal pigment, this black stuff in the middle there. It's actually yellow. And in MacTel, it's the only condition that we know of where that just goes completely missing. So this test is very useful in MacTel. And also it helped us to find that it actually runs in families. It's got a very strong genetic component. So here's the daughter of someone who thought they were normal, but you can just see they're starting to lose the luteal pigment here and starting to lose the luteal pigment there. And she ended up started losing vision about 10 years later. So we went after trying to find an eye with MacTel to try to find out what was going on. And we went to the Iowa Tissue Bank in America, and they had 5 eyes they thought they might have it, but we knew that this is the one that had it because you can see the loss of the luteal pigment on the photographs they took of it after the patient died. And what we found was very, very surprising. This is the macula here in cross-section, and these are the Mueller cells, these supporting cells I told you about, that support all the photoreceptors, and they're normally expressed in the peripheral retina, but in the macula they're completely missing. And this is the first time that we'd seen this for any disease. It's quite a specific finding, a very surprising finding, but it completely changed our understanding of what MacTel was. So then we took a mouse model in the lab here at the Safe Site Institute. We knocked down these Muller cells. And if you see here in this diagram here, this is where the Muller cells are in the middle of the retina. And these green dots means that they're dying. And so as soon as you sort of start knocking them out, they start dying here. And then about 2 weeks later, the photoreceptors start to die. And it looks like something just like MacTel. So we reproduced MacTel in this mouse model, and then we started testing treatments. And here you can see another way to look at the photoreceptors. If you just look in through the pupil, this is sort of en face imaging, so you're looking at the retina, and this is the photoreceptors here, and you can see all these black gaps in them. That's a regular array of photoreceptors here on the top here. And this is the mice that had the Muller cell knockout. And these are the ones that had them knockout, but we gave them this ciliary neurotrophic factor. It's a neuroprotectant. So these eyes got the CNTF, and it clearly, attenuated much of the photoreceptor dying. It seemed to stop a lot of the photoreceptors dying. So I thought, well, this could be a good treatment. And that's when we started these clinical trials of the CNTF implant about 5 years ago for MacTel. And I told you why we chose CNTF, because Muller cells we found out the Muller cells were gone, and that the photoreceptors were dying, and we know that Muller cells release CNTF to keep photoreceptors healthy. So there was a treatment that was available at the time called the CNTF implant, and it's this sort of capsule. You can see it here, and it has these cells in it which live, well, for at least 15 years, as far as we know, and they continuously produce this CNTF thing. So instead of having to have an injection every week or every month or two, you can put one of these things in the eye, and it continues to release the drug for up to 15 years. So it's very attractive for us. And this phase 3 study, which I was actually the chief investigator on this study, was in about nearly 50 centres all around the world. There are quite a few in America, quite a few in Europe and the UK, and 3 centres, Perth, Melbourne and Sydney, were amongst the largest centres of all. Sydney was actually the largest enrolling centre in the phase 3 study. And there are actually 2 studies, Study A and Study B, because for the American authorities to get a drug registered, you have to repeat the findings in a second study. So in both studies, they had to have the EZ break as a photoreceptor break. They had to have damage on the OCT scan of the photoreceptors of a certain size and a certain vision, which is better than 50% vision. They couldn't be completely blind. And the primary endpoint, or the main thing that we judged whether it worked on, was the rate of loss of the photoreceptors over the 2-year time point of the study. And then we also looked at a couple of other endpoints. One of them is microperimetry, which just measures the sensitivity of the macula, like when you do a visual field test done for your driving test. And the other one was the reading speed. So this is what the patients looked at baseline. Don't worry about too much information there. Basically, the groups were well matched at baseline. They're about 60 years old, and the average vision was about 612, which is what you need to have driving vision. So they had just about driving vision when they went into the study. And this is the main sort of outcomes of the study. This is the rate of loss of photoreceptors over 2 years in Study A on the left and Study B on the right. And the white line shows the normal rate of photoreceptor loss, and this is the rate of photoreceptor loss in the eyes that received the implant. So you can see here, actually, Study A had a major effect. It reduced the rate of loss by about 55%. So after 2 years here, they had lost the number of photoreceptors that they would have lost after 9 months if they hadn't had the implant. So it delayed the loss of photoreceptors and presumably the loss of vision by at least a year after being treated for 2 years. Study B also found a reduction in the rate of photoreceptor loss, but it was less at about 30%, still significant. This shows the retinal sensitivity, which was better in the eyes that got the treatment compared to the sham controls in study A. In study B, there's no difference between the two. Not quite sure why that was. And here you can see the other secondary endpoint was reading speed. The reading speed was better preserved in patients in study A and study B that received the implant. In terms of safety, it was pretty well tolerated. Most of the adverse events were related to putting the implant into the eye. We worry these days with the new drugs about increased rates of intraocular inflammation, but we haven't found that with this CNTF implant. So in conclusion, we've found with this study that the CNTF implant preserved more photoreceptors in 2 parallel studies in eyes with macular telangiectasia, and this was associated with better retinal sensitivity in the eyes that received the implant and better reading speed. There were no serious adverse events. The drug was fairly well tolerated over 2 years. And so now we are submitting this. We recently submitted this to the Food and Drug Administration in the United States, and hopefully within the next 4 months we'll have a decision. But by the end of the year, we may have the first treatment, because there are no other treatments for MacTel type 2. We may have the first treatment for macular telangiectasia 2, which would be a really remarkable achievement. This study has been sponsored all the way by the Lowy family, who, the guys who own Westfield. They have this condition. They've given about $100 million over the years, but it has been a remarkable contribution because it has taken us from where we were 20 years ago when we thought it was a disease of the retinal blood vessels. We knew nothing else about it. It's completely changed our conception of the condition, and now we know it's a disease of the Mueller cells, which are causing secondary photoreceptor degeneration. And not only have we understood it much better, but we've found a treatment that actually works. So that has been a major advance in macular disease, and a very large amount of this work has been done here at the Save Sight Institute. So if you'd like to have any questions on that or comments. But yes, Kathy.
How big is the implant?
It's little, but it's big enough so when they sew it into the eye, it doesn't go across the pupil. It's sort of right angles to the back of the eye. So it's pretty tiny, but but you can actually, you can definitely see it if you get the patient to look a bit to the side. They can't see it, but yes, you can see it. It's not that tiny at all on a slit lamp.
Does it give out 15 years worth of therapy?
Well, they've made these cells which produce CNTF, and you'd think it would be great for other retinal diseases like VEGF inhibitors, but the trouble with VEGF inhibitors is they're very large molecules and they couldn't get them out. The pores on the device weren't big enough, and when they tried to make it big enough to release VEGF inhibitors, the immune system could see it and attacked it and destroyed it. And so they had to be explanted. But the CNTF molecules are much smaller, so they get away with smaller pores. And but these cells have been immortalized. They're retinal cells, but they've been immortalized, and they just continuously make this protein. And they have recently explanted. The company is Neurotech. They've recently explanted one after 14.5 years, and it was still producing CNTF. So it's a massive advantage, this one and done thing, compared with ongoing injections, up to, every 4 weeks for 10 years, which, many people need to have.
Okay.
Yes, sir.
Do you have any sense of the effectiveness on eyes that are further progressed than that, say, average 6-12?
Yeah, the study A eyes, which seem to have done better, were earlier. We've gone back and had quite a good look at it. They seem to have earlier conditions. It's not going to be great for later conditions. Usually with MacTel, once it's burned its way through the photoreceptors have all gone from, it usually starts from the side and spreads into the center. once it's gone through the center, we don't have a lot of hope for that. It's a bit like macular atrophy in macular degeneration, age-related macular degeneration. Once it's got into the center, the treatments aren't great. It's trying to stop it getting into the center. One more question. Yes, ma'am.
What stage do you decide to do the implant, and are there any?
We'll see when they allow us to do it. The question is, in the study, they had a certain size break in the photoreceptor line, which you see on the OCT scan. Some people are saying, well, maybe give it to everyone with MacTel. But some people with MacTel, especially if they're diagnosed in their 60s, don't seem to progress to vision loss in their lifetime. It's the people who start in their 40s who really do badly. So we would be looking at people to at least show some evidence of progression, and that's the same with these anti-atrophy drugs that are coming out as well, before we do anything, before we consider the treatment.
Side effects from?
Well, as I said, it's fairly safe, but inevitably there'll be some. So look, I think we'll move on to our next speaker, who's Yohei Hashimoto. He's a Japanese biostatistician who works on another arm of the Macular Research Group, the Fight Retinal Blindness Registries.
Thank you for the introduction, Mark. My name is Yohei Hashimoto. I work at Save-Site Institute as a biostatistician. Today, I'm going to present on the Fight Retinal Blindness Registry, what we call FRB Registry. This registry collects outcomes of treatments for macular diseases. This is an agenda. First, I'll start with what is the FRB registry. Next, I'm going to move on to actual screenshots of FRB. After that, I'm going to move on to research papers generated from FRB registry. I'll finish with a summary. And before I explain about the FRB registry, we have to understand the randomized control trials, that is RCTs. RCTs are the gold standard of to check whether new treatments work or not. And because the random assignment to treatment or placebo makes the backgrounds of groups similar, which eliminates confounding. But there are some disadvantages for RCTs. First, RCTs are costly. Second, RCTs have ethical problems. For example, if the intervention is smoking, we can't assign patients randomly to smoking because we already know smoking is harmful for patients. Third, they have difficulty in having long follow-up periods. Finally, RCTs are done under ideal conditions, that is strict inclusion criteria. For example, very sick people are excluded in RCTs, but they have to be treated in routine clinical practice. Observational studies could deal with these problems because they track everyone who is treated in routine clinical practice. And that's where FRB registry comes in. This registry is a web-based innovative data collection tool for eye diseases. It was established in 2009, and it collects accurate, standardized, high-quality data from routine clinical practice. It's useful for observational studies, and it's also useful for doctors to easily check and compare their patients' outcomes with those treated by their colleagues. And this is the website of the FRB registry. If you Google Fight Retinal Blindness, you will easily find this website. There is a tab called Patients tab at the top of the website. And if you click on that, you will easily find your doctors are participating in the FRB registry. For example, if you type in Mark here, the doctors whose name contain Mark will be displayed at one time. Next, I'll move on to the actual screenshots of FRB registry. This is a screenshot from the actual screenshot. First, we have to decide on the disease names, like neovascular age-related macular degeneration, that is AMD, and diabetic macular edema, retinal vein occlusion, and so on. Other information include gender, year of birth, ethnicity, smoking status. We collect a lot of data about eyes. For example, ocular conditions like AMD, pretreatments, visual acuity, CNV activity, and treatment given. CNV stands for choroidal neovascularization, which is an abnormal vessel. CNV activity means that abnormal vessel is leaking or not. For example, CNV is active, doctors give a treatment, and the treatment interval will be shortened. After some data for one eye accumulates, the FRB website generates this dashboard. This is so informative both for doctors and patients. And we can easily check the trajectory of visual acuity, treatments given, and CNV activity in one screen. I'd like to summarize the pros and cons of FRB compared to other databases. One pro is it has a large number of eyes from multiple countries. Second is many fields are mandatory, so this leads to high quality data. Third, the FRB registry can follow up eyes for a long time. On the other hand, one con is this registry needs doctors and nurses to enter data, which takes time and effort. But actual time needed is less than 30 seconds for baseline visits and less than 15 seconds for follow-up visits. Another con is not 100% of visits are registered, unlike claims data. Next, I'm moving on to the research papers from FRB registry. The first one is about the comparison of different drugs for AMD. This paper was published in 2016, and at that time, aflibercept was regarded as having longer duration of action than ranibizumab. So we directly compared the one-year outcomes of these two drugs using FRB registry. Here is a result. This graph shows the visual acuity change over 1 year. As you can see, it is very similar between the two graphs, and with a very similar number of injections, about 8 injections 1 year. So we found no clear difference in visual acuity between two drugs. The important information we were able to get is there was no clear difference in number of injections either, although aflibercept was regarded having longer duration of action. The second paper is about long-term outcomes for AMD. This is the first study in the world to investigate 10-year outcomes for AMD. 2 regions were included. The first one is Australia and New Zealand, and the other one is Switzerland. Australia and New Zealand treated eyes with more injections with fewer visits, which was a new style of a regimen at the time, whereas Switzerland treated eyes with fewer injections with more visits, which was often seen in European countries and in the US at the time. Here is a result. This graph shows the trend of visual acuity over 10 years. In Australia and New Zealand, the visual acuity was quite stable for 10 years, and about 40% of eyes achieved driving vision at 10 years. On the other hand, in Switzerland, the eyes lost about 15 letters, which was far worse compared to Australia and New Zealand. So this result suggested better visual outcomes may be related to the number of injections. Here's a summary. The FRB registry collects standardized high-quality data from routine clinical practice. Nearly 100 papers have been generated from FRB registry on practical aspects of treatment of macular diseases. Automatic data extraction from health records and linkage with image data is in progress. Finally, we sincerely appreciate the patients and doctors contributing to data entry. That concludes my presentation. Thank you for listening.
So any questions for Yohei on the FRB registry? This is something that we've developed through the Shaoxue Institute. It is used now in about 22 countries around the world to track outcomes of macular degeneration, diabetic macular edema, retinal vein occlusion, and a few other things. Yes, Maria.
Would you envisage that the CNTF implant would be followed through the Fight Retinal Blindness Registry?
That's a great question, Maria. Yes. Yeah, we need to write an outcome registry, a module we call them for MacTel when they release that implant. That's an excellent question. That's what we do intend to do. Yeah. All right. Well, thanks, Yohei. That was excellent. And the next speaker is Shaoxue. The Macular Research Group has 3 units. It has a clinical trials unit, which I've just talked about. It has an observational studies unit, which I've talked about, and we also have a laboratory. And Shaoxue Zeng is the next speaker, who will be talking about her PhD, which is funded by a donation from one of our sponsors from the Southside Institute, Mary Bolton, and she's made great strides in developing ways to treat macular diseases with gene type therapies. And then we'll be followed by Matt Simunovic, who'll be talking about some surgical approaches to treating macular disease.
Good morning. My name is Shaoxue Zeng. It's my great honor today to share some of the research progress in treating macular diseases. Traditionally, most drugs are small molecules like aspirin. And more recently, we have seen the introduction of biological compounds such as VEGF inhibitors, which is very important for the treatment of macular degeneration. And most recently, gene therapy has been developed as the next generation of treatments. For my PhD study, I focused on a protein called interphotoreceptor retinoid binding protein, IRBP, which is secreted by the photoreceptor, and it protects the photoreceptors. Photoreceptors are the cells in our eye that first detect the light, allowing us to see. Without seeing, vision wouldn't be possible. So IRBP is essential for the vision of all animals, and the reduced levels of IRBP have been found in many different retinal diseases. So to address these challenges, I'm studying different ways to restoring IRBP and retinal function, including both the small molecule inhibitor and also the more advanced gene therapy. For the first method, we put a small molecule, PD, in human retinas grew in the lab in a test tube and in mice model with retinal diseases. To be clear, I will show the mice data in detail. So how did we do this? We tested the mice that had an injection of the drug in their eyes and compared them with the mice that didn't get the drug. The eyes that get the drug showed better results than the eyes didn't get the drug when they are in response to intense light. If we look at the bottom left image in the treatment group, these are increased levels of IRBP shown in purple, which the control mice didn't have. And these increased levels of IRBP help prevent the photoreceptors. In the treatment mice, there is a low green staining, which shows the death of the photoreceptors. So the drug prevents the death of photoreceptors in the treatment mice. Here are some OCT scans similar to the ones we got in hospital for retinal examination. In the control scan, there are more dead cells, but there were not any in the treated mice. If we look at the electric response, the higher electric response in the treatment group indicates that our drug can help the retina to function better. The previous slides focused on trying to restore IRBP and retinal function using a small molecule inhibitor. Is that all we have? No. The next method I am exploring is gene therapy. But there are still challenges we need to solve. As shown at the top here, we need to pass through multiple barriers of the eye. We need to deliver the therapies to particular retinal cell types. We need to carry different forms of the therapeutic target together, and we need to ensure longer effects. To address these challenges, we use lipid nanoparticles, also known as fat droplets, as a drug carrier. They can penetrate the retina better, target specific retinal cell types. They can carry different types of therapeutic cargo and ensure a longer effects. This is what a fat droplets looks like. They can incorporate gene therapy materials inside them and deliver them to specific parts of the retina. And this is how we prepare them. The genetic materials were dissolved in the water. Lipids were dissolved in the alcohol. We then mix them in the microfluidic system. This process will result in the fat droplets that are similar to each other and encapsulating the genetic materials efficiently. The process can be scaled up for use in human and ensuring a consistent product each time. So to test whether we can deliver the gene therapies effectively to the retina, the first gene we deliver can make the cells show a green protein. We injected the fat droplets carrying the gene into the mice. And we saw that we have a formulation that targets the Muller cells. Muller cells are very important in the retina as they support all the other cells in the retina. In the top panel, you can see the green staining indicates the Muller cells. You can see here the green on the top, which the green protein is made specifically in the Muller cells. We have another formulation to target the photoreceptors. In the bottom panel, cells in red are the photoreceptors. If we look at the green distribution, the distribution of the green protein is in the photoreceptors. As a result of this, we can deliver the genetic materials that Muller cells need only to Muller cells, and what cone photoreceptors need only to cone photoreceptors. This increases the efficiency and decreases the side effects. This is our development pipeline. We design RNA drugs depending on our disease target. I explained to you about IRBP, but there are other targets we have. We formulate these RNA drugs into our fat droplets. Then first, we tested these fat droplets in the test tube, then in mice model, and the human retinas growing in the lab from post-mortem eyes. If we pass all these tests, we can move on to phase 1 clinical trials. We might also combine these RNA lipid nanoparticle drugs with current treatments, such as VEGF inhibitors, to achieve better outcome for our patients. In summary, my research has identified the IRBP as a potential therapeutic target for macular degeneration. The development of the lipid nanoparticles, the fat droplets drug carrier, has enabled us to deliver the gene therapies directly to the retina. And this work opens new doors for using RNA therapy in treating macular diseases, with implications far beyond just the IRBP-related conditions. These are part of the works for my PhD study. I can never express enough thanks to my supervisors, Professor Mark Gillies and Dr. Lin Ru, and to all the wonderful team at SafeSci Institute. Today, I want to give special thanks to my scholarship donor, Ms. Bolton. She is an AMD patient, and she undergoes the frequent intravitreal injection. She has always shown very great interest in the research progress of my research. And it's my great honor today to have her here, just sitting there to listen to my presentation. And now I have finished my PhD and continue to explore this research project as a postdoc. As a postdoc, I really hope these studies can be translated into clinical treatments and help everyone. Thank you all for listening.
Thank you very much, Shaoxue. That was a fantastic presentation, very moving. Yeah. Does anyone have any questions about using, these lipid nanoparticles to treat retinal macular diseases? Yes, Maria.
We're currently using the adeno-associated virus vectors for the GMOs. How long do you think it is that we might start clinical trials in using the lipids as the?
Well, currently, because of the vaccination development, like COVID vaccination, the Pfizer and the Moderna, they are all lipid nanoparticles encapsulating an mRNA, the gene therapy since inside. There are also some other drugs, which is lipid nanoparticle-based drugs carrying gene therapy, can be used in other parts of the body, like in the liver, but not in the eyes yet. Recently, we are doing the preclinical study. We are getting quite good results in the mice model, in the ex vivo human retinal explant. I think maybe in the near future, we can push this forward to the clinical trial for the retinal diseases.
Thanks, Shaoxue. So that gene therapy, everyone's heard of gene therapy and cell therapy and mRNA therapy is another thing. As Shaoxue said, that was the many of the COVID vaccines are mRNA therapies. One challenge is developing the therapy, but the other challenge is getting it there and to the cells that you want, so that you can get a high expression in the retina, particularly the photoreceptors, which aren't necessarily all that easy to get to. So what we've been working on with Shaoxue is using these fat droplets or the nanoparticles, but Matt Simunovic, who's a retinal surgeon, also a very dedicated academic doing medical research, he will talk now about surgical approaches to gene therapy in the retina and macula.
Thank you very much, Mark, for the introduction. So as Mark said, I'll be talking about the surgical delivery of therapeutics to the retina, and I'm specifically talking about gene therapies, but it's applicable to other therapies such as cell therapy, for example. So by way of overview for my group, it's called the Retinal Disease and Rescue Group. We work both on laboratory research as well as clinical research. Our lab research covers gene therapy, such as optogenetic gene therapy, cell therapy, as well as more recently bioglues for retinal detachment repair and for closing macular holes. We're also involved, as Mark said, in assessing surgical approaches to delivery of therapies to the retina, as well as developing and testing new ways of examining retinal function in patients who have retinal and macular disease. We're involved in several clinical trials and also in disease registries. So for this talk itself, I'm going to cover how we deliver gene therapy to the macula currently. I'll touch specifically on work that we've done looking at the recovery of both retinal structure and function following submacular injection. And then I'll talk a little bit about a clinical trial that we've conducted here at the SafeSight Institute and Sydney Eye Hospital, comparing two competing surgical approaches to deliver therapeutics to the macula surgically. So as we've heard from a great talk from Shaoxue, DNA, which is used for gene therapy, doesn't easily get into cells, and we need a means of getting it into the retina. And to date, as we heard from one of the questions, the principal way of doing this has been via viral vectors, and the most commonly used viral vector is adeno-associated virus. So in its wild-type form, it doesn't cause any known human disease. It's used in the only approved gene therapy in Australia, which is Luxturna gene therapy, which is used for patients with an inherited retinal degeneration called Leber congenital amaurosis type 2. So how do we get the gene therapy into the eye? There are a number of different approaches which have been used in different clinical trials. Possibly the simplest approach is to perform an intravitreal injection. This is demonstrated here, where we inject the gene therapy solution into the posterior cavity of the eye, much the same as you would inject an anti-VEGF agent. It's attractive because it's relatively easy to perform. It can be performed in the rooms or in the consulting room rather than in theatre. The alternative approach, and this is how we deliver Luxturna gene therapy, is via surgery. So first of all, we perform a micro keyhole operation called a vitrectomy, where we remove the gel that fills most of the inside of the eye, the vitreous humor. Then we use a very fine tip cannula to inject a small volume of solution underneath the retina. So I'll go through this in more detail a little bit later. So when people started performing gene therapy, the macula was excluded from gene therapy, but more recently, surgeons have begun deliberately detaching the macula as part of the therapeutic process. And when this was first performed, there was an editorial in Lancet saying gene therapy has arrived at the macula. And something that hadn't been explored in great detail, and which I was interested in with my colleagues who I worked with at the University of Oxford when I was a fellow, is are there any subtle changes to the macula after we perform a subretinal injection targeting the macula? You know, most of my time doing emergency surgery as a vitreoretinal surgeon, we actually fix retinal detachments. In this instance, we're creating deliberately a retinal detachment, albeit a limited one. So we looked at patients treated consecutively as part of a phase 1/2 trial of gene therapy for a condition called choroideremia, which affects males. Around 1 in 50,000 people are affected by this condition. It typically affects your night vision in the first or second decade of life, and then goes on to affect macular function by about the fourth or so decade. So we looked both at structure and function after a delivery of a gene therapy solution of a volume of 0.1 of a mil. And what we found was, interestingly, it's a bit difficult to see in the projection here, but the fluid in a treated eye has completely been reabsorbed overnight following the injection. And there's no significant change in retinal thickness. And we found this for the consecutive patients who we analysed as part of this phase 1/2 trial. So how about function? So we looked at several aspects of visual function, including visual acuity, ability to read a letter chart. This was unchanged following treatment. And in fact, by 1 month following treatment, patients' treated eyes were doing better than control eyes. So they were treated in one eye only. Similarly, their sensitivity on microperimetry, which we heard about earlier on from Mark, the ability to see small points of light within the central visual field, was back to baseline by 1 month following treatment. And finally, patients' ability to discriminate between different colours was at baseline by 1 month following treatment. However, we knew that this probably wasn't all of the story. So we knew this from animal studies where retinal detachment was created deliberately. And what we knew from those is that there are changes in the photoreceptors. We heard about them in the last talk. So the part of the photoreceptor which absorbs light is called the outer segment. And this gets partially cut off or shorn off as a result of a iatrogenic or a deliberate retinal detachment. And we reasoned that we should, if we could, be able to demonstrate a loss of the little molecules that detect light within the cone photoreceptors. And these molecules are called opsins. How did we do this? We used something called a Rayleigh color match. This is where we mix red light, pure red light, with pure green light to match a yellow light. And if your opsins are depleted, you'll need more red in that mixture to match the yellow light. And sure enough, one of our patients, the only one who demonstrated a slight thinning following the procedure, demonstrated this red shift. It's called pseudoproton anomaly, which had partially recovered by the final follow-up point at 1 month. So although they do appear to recover function adequately by 1 month, and this patient's visual acuity was back to baseline, they may have subtle changes to their visual function that don't recover so rapidly. So moving along to the trial that I mentioned earlier on, just by way of background, I have some videos here of me performing gene therapy surgery at the Children's Hospital at Westmead. As I mentioned earlier on, to do gene therapy surgically, we first of all perform an operation called a pars plana vitrectomy, where we remove the vitreous. We then inject a small volume of solution underneath the retina. And in the early days of gene and cell therapy, it was implicitly assumed that if you standardized all the steps of surgery, you should end up with a fixed amount of solution underneath the retina. And people began to question whether or not this might be the case. And in particular, two kind of competing approaches were developed to performing a subretinal injection, which I'm doing here. You can see a little blister is raised underneath the retina, and then I perform an OCT scan to confirm that I'm in the correct surgical plane. So the two competing approaches are called one-step and two-step injections. So we've been performing two-step injections at the Children's Hospital. But one-step injections were the original way of delivering gene therapy. And in a one-step injection, you simply just inject the therapeutic solution underneath the retina, and you hope that you're in the correct surgical plane. In a two-step injection, we first of all inject an inert solution, balanced salt solution, in the subretinal space. And then we use on-table surgical OCT to confirm that we're in the correct surgical plane. Once we've confirmed this, we then inject the gene therapy solution. So in this case, it's a Luxturna, and we inject 0.3 of a mil into the subretinal space once we know that we're in the correct surgical plane. So it's argued that this may lead to lower proportions of drug reflux when we're performing the injection. So we know from OCT qualitatively that drug reflux does occur, but until recently it's been impossible to measure this. The disadvantage of getting reflux is that it will lead to inflammation with adeno-associated viral vectors. It's going to lead to loss of efficacy or lack of efficacy. And finally, this medication is really, really expensive. Although it's hypothesized to last you a lifetime, it costs $500,000 to treat a single eye, so $1 million for both eyes. So until a few years ago, we had no handle on how much drug is retained in the subretinal space until Cynthia Toth's group looked at this in cadaveric porcine eyes. And what they found was that reflux was significant. So at best, it's 12%. At worst, it's 96%. So obviously, it's going to be a big problem if you're injecting a very expensive medication that you're hoping will last a lifetime in a patient, and only 4% of it stays underneath the retina. So we developed here at the Safe Sight Institute in the eye hospital means of tracking drugs that we inject underneath the retina. And the example here I have is of injecting a clot-busting medication underneath the retina in a patient with macular degeneration who has a large submacular bleed. So the clot-busting medication is called TPA, but it's been mixed with this inert salt called sodium fluorescein, which we use all of the time. Clinically, it glows green. So you can see qualitatively quite well what happens when I perform the subretinal injection. It spreads underneath this bleb, this subretinal bleb, but also you get a little bit of reflux of solution after I pull the cannula from the subretinal space. So it's possible to collect all of the fluid from the eye at the end of such cases, which is what we do, and then we send that solution off to the lab, and we're able to measure the concentration of sodium fluorescein by putting it through an instrument called a fluorophotometer, which pretty much measures how coloured the solution is. We know the volume quite easily by measuring it, and we can calculate from those measurements how much of the drug has come out of the subretinal space and therefore how much remains in the subretinal space. And we're using this technique to track the fate of subretinally injected TPA in patients who are undergoing either one-step or two-step injections here at Sydney Eye Hospital. And we've published both the protocol as well as the technique itself. So we haven't fully reported the data, but we've treated the final patient, and on average, there's not too much difference in terms of the proportion of drug which remains in the subretinal space following these injections. However, what we did find is that there's a statistically significant, a greater probability of variance if you're doing a one-step injection. And this really correlates with what we find surgically, is that sometimes when you're trying to perform a subretinal injection, you just simply cannot find the correct surgical plane, and you spend a lot of time and effort, and you waste a lot of medication potentially if you're doing a one-step injection trying to find the correct plane. We thought that two-step injections might take longer, but on average they do not. We'll formally report the findings later on this year. So in summary, the approach that I've been talking about, subretinal injection, is the only approved means of delivering a gene therapy to the retina at present. In the future, as we've heard, there may be other ways, other vectors which may change our approach. Iatrogenic detachment of the macula appears to be well tolerated, both in terms of structural recovery as well as recovery of function, though there may be some very subtle alterations that are only found on specialised tests. We've developed a means of quantifying the amount of drug reflux when performing subretinal injections, and the trial that I spoke about just now will inform surgeons as to the appropriate means of delivering subretinal gene and other therapies. Thank you very much.
So are there any questions to Matt, or we've got another 10 minutes before we have some refreshments. So if anyone has any questions at all about anything they want to ask about macular disease, Matt and I'd be happy, or any of the speakers would be happy to answer them. Doesn't have to relate to what we've talked about today. Does any? Oh yes. Well, hold on. Does that? I was going to. Oh, Kathy.
So how do you get the gene down?
That's a thorny question. That's the sticker price. I don't know what the government's actually paying. Part of the problem is that these medications are expensive to develop and test, as you know, and it takes a long time. So the gene for that condition was first cloned in the early 1990s. They developed a gene therapy, which they tested in animals, a large animal model in the early 2000s, and the first human trials were commenced in around 2005, 2006, and it only became FDA approved in 2017. So they've got all these R&D costs to cover, if you will, and other costs as well. And there are a few patients that have this condition. It only affects between 1 in 300,000 and 1 in 1.2 million. And I guess that the fact that it's rare and the development has been expensive means that the treatment is concurrently expensive. So, bargaining down the price in the future, the price may come down. I'm not sure what the government is actually paying. And for other conditions, the treatment may be less expensive if those treatments are for more common conditions, or if those treatments are causative mechanism independent or agnostic. So we're working on one such approach in my lab called optogenetics, which should be suitable regardless of the gene that causes the condition. So that's the other problem with developing gene therapies, is that, just for inherited retinal degeneration, leaving aside macular degeneration, more than 300 genes or loci have been implicated.
Rhea?
What surgical interventions are currently in the FRB registry?
So currently we have a specific registry for people with inherited retinal degeneration, and part of it covers Luxturna gene therapy because it's the only one currently available. The registry, as far as I'm aware, Mark will be able to speak to this better than I will, also captures things such as cataract surgery, etc., which are performed on patients within the registry. And finally, there are other registry modules which cover surgical outcomes. So, case in point would be the glaucoma registry.
Well, that's right. There's no specific surgical ones, but the glaucoma registry captures outcomes of glaucoma surgery. There's corneal registry, which would include some corneal interventions. The melanoma registry would include some interventions there. Is there surgical intervention for ROP?
Yes.
Yeah.
Infrequently.
Infrequently, yes. So that there would be some for retinopathy of prematurity, but there's no specific surgical ones. We might do a cataract one. They already have one, but it's not performing very well. All right. Well, I'd like to thank everyone for coming along, and see you over. There's some sandwiches there and some drinks.
Oh, yeah.
Yeah.
I spent 2 days.
So then there are a few things. The other thing that they could do potentially, the problem is that if you have the bad keratopathy, that also tattooed on, so they can, it's not done very much. They wouldn't have done it for a long time. No, so it's not insofar that it's better that if you're not seeing and they're worried about having surgery, it's a way of doing something that's not a positive operation. So it is done, but I just asked them about it. You can ask that the uveitis can send you to somebody in the cornea service. Yeah. Yeah, just the cosmetic. Yeah. So that's one thing that could potentially do. Think about it.
So actually, if I had 2003 and by 2004, that should have.
Last week, I should say. Dave.
He was so smart. It's John.
Well, we don't know who. Then maybe Shirley might have done it.
Yeah, so I think that was the mother. Very one side. Okay, well, in that age, you've got like something. Steps. It's great.
Where are we going I can say that it's
It's working. It's like
This is the step. Start away.
We have to do it. It's not that easy. Like the one we always do the fish and you don't put that like this having fish. I was thinking actually be a final very friendly and everybody say like yeah, it's good to hear that it's got it on the different. To know what you're saying.
we're finishing
I get dry as hard for MacTel anyway. It's dry eye.
Yeah. It's something like it's crazy. So I can I do. We are in a we finally we got a bit.
predominantly, yeah.
I mean,
You know how they put up application.
I might be going back to Europe.
Yes. Very good.
It is also
So when did you? Just to get something. That's the brush being that's the I think all doctors know about it somehow because just their own doctors.
Yeah, but then like would they send somebody over to do
No, you have the site like when I was at Shaoxue, I was asked to enter the patient data from EIP. But Emily out.
I think you just make an account.
Yeah,
Just make an account and then
you have the doctor, information, and every time you get a new patient or they do a follow-up visit, you add their data.
Oh, right.
So it's like your own book. Like,
there's a lot of missing.
and then you don't get any. You don't get anything from it.
No, you get paid.
No, you just add to help.
Yeah, so to improve the accuracy would be better for RP and code. Yeah.
But that needs a lot of time.
That's
I think I'll be back in July.
I am.
You will?
I'm not.
Do you miss it, huh? Do you miss it?
People.
How they make it do it? How are you? Well, at least he's doing well, right? At least he's doing well. Now you can do
Yeah, if you want.
money.
What's he made up? That'll be a good. But you still have that?
On a Monday.
Yeah, just think it's like.
Although, because like they're
Why is Rueno? Oh, Zach is still on there. She was before Zach can come.